Welcome to the Birth Blueprint, where we'll be having conversations discussing birth and maternal health care. My name is Dr. Nicola Pemberton. I'm the Medical Director for Artemis OBGYN and the Birth Center of New Jersey.
Hello, I'm Michelle Gabriel Caldwell, and I am the doula coordinator for the Birth Center of New Jersey.
Hello, my name is Chidera Chima. I'm a certified nurse midwife at Artemis OBGYN and the Birth Center of New Jersey.
How do I know as a patient what early labor is?
Well, early labor can start with contractions, right?
Right.
I mean, that's people don't understand what labor is. Labor, by definition, is contractions and cervical dilation. That's labor. Contractions plus cervical dilation
Cervical change.
equals labor. So if you break your water, that doesn't mean labor. You could break your water and not have a contraction. Contractions may start later or it may not start at all, and we may have to trigger that. But by definition, labor means contractions plus cervical change or labor or dilation. But for early labor patients, that labor can last for what? 12, 18, 24 hours?
For first time moms?
Yes, it could last
on
for a
average
while.
about 27 hours.
Yeah.
And a lot of people aren't prepared for that. They
This is
don't
true.
realize that that is the possibility, that it can take that long
Yeah.
to have a baby.
Correct.
And mostly it's because, what are they seeing? In the movies, somebody jumps up
After the water breaks?
after the water breaks.
And then the baby's coming in within minutes because they have to keep that 30-minute episode. No, just kidding.
The episode is
The
timed
episode
to a
lasts
minute.
60 minutes in Grey's Anatomy or something, 30 minutes if it's a sitcom. And the baby comes right after that, which is absolutely unrealistic. So,
Completely unrealistic.
yes.
So if I start getting contractions, that doesn't mean I'm in active labor.
No.
Right.
It just
You're
means you're
in
getting contractions.
Early labor.
Right.
Maybe even prodromal labor,
Correct.
which could be days
Yes.
or a week
Of contractions.
Correct.
of cramping.
Yeah, so people might say, I was in labor for 5 days. Not necessarily. You are experiencing contractions or cramping,
And discomfort.
but that doesn't mean your cervix is changing. It doesn't mean you're making progress. It means your body's trying to do something, but it hasn't transitioned into that. Now I'm going to start dilating your cervix so we can get this baby out.
What's the difference between contractions and Braxton Hicks? Because you hear that a lot, right?
Correct.
Yes.
Correct. Well, first and foremost, location. You know, location on your body. A lot of people will describe Braxton Hicks as a tightening of the muscles, and it feels like a wave, and it's going from the upper to the middle part of the abdomen, where they might describe contractions more like, I feel like my period's coming. I feel a little crampy. It's all the way in the bottom, which is where it wants to effect change for the cervix to start to dilate. Would you agree?
Right. So in class, basically, I start telling people that it's really just practice. It's practice for the uterus, it's practice for the baby. Just so it's not like a massive shock for either one of them. So you're feeling some movement and tension of the uterus so that both of you kind of know what's to come. There are some times when Braxton Hicks or practice contractions can actually cause some change in cervix, but not really a lot. Like, it's not really going to move the needle so far where we're about to have this baby today. So when we're looking at practice contractions, and I like to say practice instead of Braxton Hicks
Pre-labor.
because it's named after a dude and I don't care about that. So, you know, it's practice. And I let them know your body's doing what it's supposed to be doing.
Yeah.
Right? It's
Giving
getting
Braxton
ready.
Yeah.
any credit.
We used to
Nah.
call it false labor contractions, which is
Correct.
inappropriate. It's not false, it's pre. It means I'm about to kick off something, but I don't know when that might be. It could happen for days, it could happen for weeks. But it's pre-labor, meaning it's just giving you, as Michelle was saying earlier, an introduction to what you might feel before it starts to kind of say, I'm going to transition to the real deal Holyfield, where it becomes a little more intense, a little more crampy, and feel like you're having
Yes.
a period, and your period don't want to stop. And
You asked me the difference between practice and the real thing. So practice, you can walk, you can talk, you can eat, you can drink, you can do all of those things through those contractions. If it's the real deal and you are really in active labor, you have to stop and have you have to stop and really pay attention to what your body is doing.
Right, you gotta concentrate on getting through the contraction.
Right.
So you might have to breathe. You might have to shift positions. You might have to, but whatever it is, you're not like, let me go have that chicken leg. No,
Yeah.
you're not thinking about food at that moment. You don't really feel thirsty in that moment. You're just going,
You forget.
give me a moment.
Yeah.
Let me,
It's like, stop talking to me.
I
I gotta have this.
I gotta go through this. I gotta go through this. And so when we talk about that, when you're saying getting into active labor, what we understand current definition or guidelines for active labor is anything 6 centimeters and more. So a lot of the times when people get to 4 centimeters, they're thinking, this is it. And back in the day, they used to be that way, even in hospital settings. People used to use that as a guide, as to saying if a patient wanted pain medication
Yeah, that
and
was
they
the
want an
time.
epidural, they can't get one until they're 4 centimeters. But that's still early labor. And they could be 4 centimeters for hours before they kick into an active labor setting. So,
Or days.
oof, boy. There was a question asked earlier about whether or not it is a concern when a patient is contracting every 2 minutes. We talk about we give instructions to patients when it comes to notifying their practitioner or their provider or their doula when they're contracting. And granted, we give the basic 511. You can contract every 2 minutes, but it's not just how frequent the contractions are, it's how long each contraction is lasting.
The duration.
Okay. So frequency, duration, and then also how long those contractions are actually
And
going on
intensity,
for.
yeah.
Yeah,
What
some
does
people,
511 stand for?
So it's basically having contractions every 5 minutes. The thought is that each contraction lasts 60 seconds, which is a minute, for an hour or longer. So that's the 511 rule.
So it's not like this random, oh, I reached 5 minutes, and then the next contraction is not happening for 7 minutes or 12 minutes.
So
It-
it's consistently 5
It's the
minutes.
consistency of 5 minutes apart, lasting a minute, and doing so for at least an hour.
right,
Yeah. And so when you're talking about that person coming in at 2 minutes apart, thinking, oh, I've reached this goal, but if the contraction itself is only 15 or 20 seconds long, then we're not in active labor.
and we're not dealing with effective contractions as yet. It's the same thing when people, I guess, use techniques, and I'm not going to mention natural labor techniques yet, because that's something we can go into in a couple seconds, but when people use the induction agents such as castor oil,
No, we don't want
Big.
to do that.
big E. There are ways to do it, and there are a lot of labor professionals out there who know how to do it safely. But unfortunately, a lot of people who might go on the internet and say, I was told, or maybe a family member says, try
There's
this.
some concoction that they've been given, and it's too aggressive.
It's aggressive, and not realizing that they're creating so many fluid shifts and changes in their body that can lead to some sort of a dehydration picture.
Completely.
And as a result, you can get contractions back to back, sometimes 1 to 2 minutes apart, but they're not effective, they're not efficient, they're not lasting long for each one, and they're certainly not changing the cervix. And all you look like if it was you're in the desert, like dry, like Tyrone Bigum's. Just dry and crusty and dehydrated.
So is that castor oil? Is that a effective way of like a normal intervention? Is that a natural intervention?
It's still medical induction.
Correct.
Because it is a medicine, whether it's not a prescription or not, but it's still medicine that you are giving to your body to actually try to change the trajectory of labor, or maybe even spontaneously induce.
Got it. Okay. So here's my question. I want to distinguish what the difference is. I hear a lot about birth centers. And I guess after COVID, a lot of people didn't want to go to the hospitals. What is the difference between a birth center and a hospital?
I think we can all answer that.
We
I
can,
feel like a birth center is kind of like the perfect medium between, the hospital system and like interventions, and then the home birth where you kind of just want to do as least interventions as possible. It's kind of like the perfect medium to say that, hey, I want to let my body do what it needs to do as natural as possible, quote unquote, whatever natural may mean to the patient, but still having that reassurance that if anything may happen that would require like a higher level of care, we're in between where we can get you to that hospital that's close enough or to someone who can help you with whatever is happening at that point that may need an intervention.
And how does that differ from a hospital? So if I want the benefits of a hospital, why wouldn't I just go to a hospital?
Absolutely. You can
That's
go to the
true.
hospital and have those benefits for sure. The difference, I think, is really focusing on the individual who wants a low intervention space, who wants time to labor, who doesn't want to be on the clock, who wants to have freedom of movement, who wants to be able to do this without, an anesthesiologist present, right? So really focusing on normal, natural, physiologic birth. And that person has to be low risk though. So those options are only for individuals where they or the baby and the baby are healthy, right? So there can't be any issues with either one of them.
Right.
And that would provide for them more options. So a person who's low risk can have a choice. They can have a birth at a hospital, they can have a birth at home, they can have a birth at a birth center. And it's really about what they want. So I think what's beautiful about a birth center is that it encompasses all of those values of providing the space, the warm, sacred centeredness of what birth really should be. In that space with a little level of kind of oomph of support and care from a midwife or an OBGYN or a nurse in that space too.
I just think the birth center, home birth is very similar, except we do the cleanup. No, we do the cleanup at the birth center. Also, there's another thing that you mentioned when it came to freedoms to eat, drink.
Right.
There's a lot of stipulations around what you can and can't do when you are in a hospital setting, especially if you get an epidural. It's very clear. You cannot eat, you cannot drink. Maybe you'll get some ice chips. That's just a standard, and you'll automatically always get an IV.
Yeah.
That just comes with the territory. That's hospital policy, and that's nothing against that. That's part of the policy. The goal is to be safe in a situation what might be high acuity, especially if you're dealing with higher risk patients or a patient that was low risk and became a little more high risk, meaning they had to either be risked out of the birth center prior to coming into the birth center, or they risked out while they were at the birth center, or they had a great delivery but required a little bit of follow-up or evaluation in a hospital setting. These are the things that come with the hospital policy. So you're going to need an IV. You want access. They want to make sure that if we have to deliver medications, we want to make sure we have easy access, because you don't want anything to happen so urgently or emergently, and you don't having access to the patient to give her what she needs in that moment. So that, whereas the birth center, you're not going to be inundated per se with an IV. There are times where an antibiotic might need to be administered, and that's something that comes with the normal screening that we do in our prenatal care setting, like an antibiotic to kind of protect the baby from any bacterial exposures during the vaginal delivery, but they still are free to be able to move around, eat, drink, walk, whatever that might be, and
So what are the benefits of eating during labor?
Sustainability and energy so that you can get through that labor. Just think about doing anything that requires a lot of work without eating. A lot of people hit a wall, they can't get through it. Even people with the intentions and the desire to want to have a natural birth usually get into a space where they just can't go anymore because they have not had the opportunity to fuel themselves. So it's important to be able to eat because it's a human right and a human necessity.
So what disqualifies you as a candidate for the birth center?
I would say, first and foremost, twins.
Multiple.
We've had multiples, patient who comes in and said, well, I had 3 vaginal deliveries and I'm having twins. I had all normal deliveries. Can I come to the birth center, and we'd be like,
We're so sorry.
we would love you to be at the birth center, but we cannot. It's only one baby at a time. You know, we can only take care of one baby at a time. That's not considered a low risk situation, no matter how low risk the mom may have been in her previous deliveries. Having more than one baby is not considered a low risk. As we discussed, diabetes. Diabetes that might be acquired in the pregnancy, we may call gestational diabetes. Low risk, a patient who can remain low risk even if they have gestational diabetes, as long as it's diet controlled. And it has to be well controlled on diet. But once we have to initiate medications, such as either oral medications or insulin, or if you had diabetes prior to the pregnancy that required insulin, then in that situation, no, that's not considered a low-risk pregnancy. Number one, unfortunately, blood pressure. Whether you had it before, even if you've had low-risk deliveries, even if you have the best controlled blood pressure, if you walk into the pregnancy with blood pressure, whether you're on medication or not, it's not considered low risk. If you acquire blood pressure in the pregnancy or preeclampsia, which is what our biggest risk factors are, unfortunately, these days, especially among women like us, black and brown women, that is considered immediately risking out of the birth center. What other things we can think of that say, hey, this is not a good candidate?
Well, someone who's already had a cesarean the first time and is looking to have a VBAC.
For the first time.
For the first.
Right. Vaginal births after C-sections are all right at the birth center as long as they've proven their pelvis, meaning they've had a vaginal birth after C-section. It gets a little tricky when you're talking about people who've had a vaginal birth after C-section and then another C-section, and now we're talking about 2 C-sections. Things get a little, we wouldn't really want to have a patient, even if she's had a vaginal birth or VBAC, to have 2 previous sections and then come in and try to attempt another VBAC. That's not considered a low risk.
Okay. Now, can I go to the hospital and have a natural delivery with no intervention?
Absolutely.
Of course.
Again, it's your choice.
Yeah.
As was said before, you can, when you're low risk, you can choose to deliver anywhere you want, even on Garden State Parkway. No, just kidding.
Are you able to have a birth plan in a hospital
Yes.
Yes.
and have that followed?
I think it's important to go over it with your provider that you're seeing, just so we can set realistic expectations, because it is right that it's your birth and we like things to go according to how we planned them, but there are, like Dr. Pemberton was saying, there are policies that certain hospitals do follow just because of that's just how it is, and certain things can't be done in a hospital. And it's important to just, educate your patient on why that is and alternatives if that's possible, and then the things that are okay as part of the plan.
What is the importance of a birth plan?
To give the patient autonomy, to let them know that, hey, this is what you would like to happen, and we just want to it's your body, it's your pregnancy, it's your child, and this is something that's going to follow you throughout the rest of your life. So it is important to each family that how they want things to proceed is respected and followed, because that's just your right as a human. So.
I like to, when I'm teaching classes and I'm talking about birth plans, I'd like to have my students kind of think about their top 3 non-negotiables. Like, what are these things that absolutely have to be present for their birth experience? And it could be whatever it is personal to them. It doesn't necessarily always have to be a medical situation. It could be who they want in the room. It could be music that they want to play. It could be, sounds, food, whatever. Like, those types of things might be more important to them. Some people want exclusive freedom of movement, right? So wanting to wait to the absolute last minute to get that epidural if that's something that they're looking to do. So based on those non-negotiables, then that's where I help them create and craft a plan that makes sense to their health, their baby's health, and their birthplace. because where you birth matters. Like how you make that decision and what you want to put in that plan has to be specific to where you're going to give birth and who you're going to give birth with. So, like Jadira said, we're talking about realistic expectations. You can't, there's specific things you're not going to be able to do in a hospital space. But if you have, the wherewithal to go, okay, well, I know that I'm not going to be able to do that, but I want this instead, that's usually great, right? Like you can work around those things. So it's really about putting that plan together that makes sense for everybody, and the doctor needs to be in on it.
Yeah.
Like it, I think of it.
Your whole provider team should be in on it.
Yeah, it's like a script.
That's the biggest thing, especially if you're going into a hospital setting. If your practitioner or your provider knows, whether it be your midwife or the OBGYN, knows what your desired plan for your labor, for your delivery, for your birth, this is where you are hopefully getting the people who you have entrusted to care for you to be a part of your plan. And in being a part of your plan, it allows them to also be your advocate as well, to see if those plans can be followed. Again, sometimes, as Michelle was saying, you got to make sure expectations they're not going to always be steeped in reality sometimes. But here's expectations, here's reality, and we're going to try to work with you to bring something in the middle. We kind of bring it all together if we can. Sometimes things might, change a little bit here and there, but we're trying to prevent it from going left. And so letting us know what you desire can help us to be able to say, hey, let's educate on where that will be, true, that we can follow through with that, where that might be kind of false, where we may not be able to, and where we can be able to have alternatives and be able to have options and plan Bs and plan Cs, but then also trying to say if we can keep that within the realm of what you desire for your birth.
But it's key to have that flexibility in the plan. The plan, a lot of people don't like the word plan, right? You may be thinking of it as preferences or the landscape, or I had somebody who gave me what they called it birth vibes. And I thought that was super cool. I'm like, yeah, this is the vibe we're at. Like, this is where we're chilling, you know? But having that level of flexibility to say if something shifts and changes, right? Now we can't birth at the birth center. Now we have to go to the hospital. So how do we bring this birth plan to the hospital, right? Or we're at home birth. How do we bring it to the hospital? Like whatever that transfer looks like needs to be part of the plan too.
I'm glad you made that point too, because a lot of the times people have a misunderstanding that even though home birth is the ultimate low risk and type of birth you can have in your home, they think that birth center is intermediate and then hospital. So they think if something happens at my home and I'm not doing well when it comes to my home birth at home, can I come to the birth center? And we're like, no, you cannot. Because home birth and birth center, as I said, are pretty much on the same, on the level. The only thing is we do the cleanup. I said that before, and I think that's the only difference. Otherwise, if there's something that's out-risking you from a home birth, it's already out-risked you from the birth center, and whatever is the next step is usually a hospital.
A lot of the times I'm asked, if I don't have a doula, will my midwife support me?
So what say you?
Yes, of course. That's what we're here for. We're all a part of the labor team, right? So we're here to be of service to you. There are a lot of patients who don't know what they don't know. And as much as you can prepare, you don't really know what you're going to go through until it starts to happen. So, of course, we're here for you, to assist you through all the questions, position changes, non-farm labor mechanisms to help with pain. Of course, yes. Short answer.
You guys rock that.
Yeah.
In closing, we should do this more often.
Yeah, we should. Next time with wine. No, just kidding.
No, I'm not. We should have glasses in front of us, and next time
Just
I want you
mugs.
guys to join us.
Yes. Feel free to submit any comments, topics of discussion you'd like to, or questions you might want to ask, things that we can clarify to give you some, real life situations, experiences, give you some good information, good education, and
What do you want to know from a doula,
Yeah.
a doctor, and a midwife?
there you go. Walk in the bar. No, just kidding. And we'll have the wine. No.